chair of the Retirees chapter. This meeting is probably, I shouldn't say probably, this meeting will be the most well-attended retiree chapter meeting ever, for obvious reasons, because we're discussing an issue that touches a raw nerve for retirees, and that is the issue of our healthcare coverage as we age. I want to get to that immediately. I first of all want to thank Barbara Bowen and Donna Costa, whom you both know, whom all of you both know, who have addressed our meetings many times and have been advocates for retirees and certainly for in-service members in the PSC. Donna and Barbara are here to answer questions, to provide context. Barbara is on the steering committee. Barbara, of course, as you know, is president of the Professional Staff Congress, is stepping down after 21 years. We're actually going to have a program with her on June 14th. And these have been 21 absolutely momentous years for the PSC. Barbara is also on the steering committee of the MLC. She'll talk about that in a few minutes. Donna, of course, is executive director of the Welfare Fund. Somebody who has talked to us many, many times, including as recently as 2 months ago. She's also on the technical committee of the MLC, which she'll explain. They don't make decisions, but they provide technical expertise to the Municipal Labor Committee, which is a coalition, Barbara, you'll correct me if I'm wrong, but I believe of over 200 municipal labor unions. Let's talk about how we're going to set up this meeting. We want your voices to be heard. I'm going to make a statement first on behalf of the Retiree Executive Committee. Then Barbara will make a brief statement. Then Len Rodberg, who is a member of our chapter, former chair of urban studies at Queens College, and a longtime renowned advocate for affordable health care for all, will talk about some of the issues that a number of you have been raising about Medicare Advantage. And then Donna will answer our questions, and it's Donna's view that this is a really different kind of Medicare Advantage plan. But lots of us have questions. Received a ton of questions just this morning, and I could not respond to everybody's email this morning. But the questions really overlap. So we've asked Joan Greenbaum and Eileen Moran from our executive committee to monitor questions on the chat. That's where you'll pose your questions. Put them in the chat now. And what we're going to try to do is collate questions so that we don't repeat the same question time and time and time again. We'll aggregate the questions into categories. We'll try to cover everything as best we can. Let me just start by reading a statement from our Retiree Executive Committee, who put together this emergency meeting. Originally, we were going to have a chapter meeting on the pandemic. Obviously, once it became clear that the MLC was seriously considering proposals for Medicare Advantage and maybe transferring retirees from traditional Medicare with city secondary insurance to Medicare Advantage. Once we understood this, we knew that we had to set up this meeting. And might I note that Donna and Barbara, I think a week ago, talked at great length and answered questions at our Retiree Executive Committee meeting. I mean, unfortunately for Donna, or maybe fortunately for Donna, she's going to have to answer those questions again, because most of you have not heard Donna yet respond to those questions. So let me just read the statement of urgent concern. New York City Administrative Code enshrines the right of health insurance for municipal employees. That right has been compromised by several recent agreements, 2014 and 2018, between the City of New York and the Municipal Labor Committee, which negotiates our healthcare benefits. In the latest iteration of those negotiations, New York City has called for more savings. The savings of the city, not municipal workers and retirees. The city has put out a request for proposals that would transfer 250,000 municipal retirees from traditional Medicare with secondary insurance from the city to a Medicare Advantage plan. There is a contradiction here. Our union is a proponent of healthcare as a public good, of single payer. Moving to Medicare Advantage, which is privatized Medicare, is a retreat from Medicare to privatized healthcare and more problematic healthcare coverage. The negotiations of the city have not been transparent for New York City's 250,000 municipal retirees. Certain paths, for example, the city saving money by self-insuring, have not been explored. There are lots of questions about what the transition would look like, about what the new plan recovers, about what happens when the Medicare Advantage contract between the city and vendor expires, and a whole host of other issues. For these reasons, we call on the PSC to push for a moratorium on negotiations between the city and the MLC, for a pause that allows for transparency, for consideration of other options, and for the voices of municipal retirees to be heard. And this was passed unanimously by our retiree EC. To start, Barbara has a few comments to make. Then we'll hear from Len. Then we'll hear from Donna and all of you will have an opportunity to raise questions through the chat. And then we'll hear from Barbara again. So Barbara.
Great. Oops, make sure I'm being heard. Thank you. Thank you, Bill. Thank you, Executive Committee of the Retirees. And it's really great to see so many people whom I haven't seen in a while, at least on the screen. I mean, I'm not seeing you in person, but I'm seeing a lot of people I've been missing, and I love seeing at the meetings. So it's really great that you're here. And thank you all. You've got 269 people on, which is fantastic. And that's testimony, I think, to how important this topic is. So thank you, Bill, and everyone involved. And thank you very much to Len, my colleague at Queens College, and also to Donna Costa, who is a tremendous representative of ours on the Municipal Labor Committee's Health Technical Committee. I'm just going to say a few words first. I hadn't heard that statement before, so I wasn't aware of the call for a moratorium. And I have to say, I don't quite agree with the sense that the right to healthcare has been violated by the 2014 and 2018 agreements, but those agreements did call for changes, right? And you're going to hear in a little bit from Len Rodberg about Medicare Advantage plans in general. And then you're going to hear from Donna about the version of that plan, or those plans, I shouldn't say that plan, those plans that is being considered by the city. And there's a distinction between those two because the city insisted on certain things from the outset in the plan that are not in many, if not most, Medicare Advantage plans. So as we listen to Len, which I think will be very important, I'm going to ask you also to keep an open mind to hear what is being considered by the city. But the main thing really I want to say is that I am here as your advocate and as the advocate for the whole membership in healthcare. And Donna is here as our advocate and our representative. We need to know what concerns you have. Some are things that maybe can be answered and won't stay as concerns, but some will stay as concerns. And we need to know those as we take part in the discussions and negotiations. I'm a voting member of that steering committee. I have already raised numerous questions. They haven't stopped the negotiations yet. They haven't put a moratorium on the negotiations, but I have raised numerous questions. I need to know everything I can from you about the questions we need to know. And I think for you, it would be helpful to know which ones have already been answered in the discussions and which ones we need to press forward with. Because Medicare Advantage is a movement from a government administered to a health insurance administered form of health coverage. And health insurance in this country is private and largely for profit. So when that happens, that puts a whole different frame on things. We are here to see if we can protect all of you, if we need to vote against those moves, or if we need to reshape them or delay them, as Bill said, in a way that will work for our members. So Len is going to talk to us, I think, and Len has taught me so much on these issues about the overall structural issue. And then I think Donna will talk more specifically about what's being considered by the city. So thank you, and great to see you.
Bill, I need to jump in before Len. This is Joan Greenbaum, and thank you, Barbara. There's still lots of people coming in and lots of questions in the text. Could we ask you to hold your questions until the speakers have spoken? Because many of these are going to overlap, and I know that they're, pressing, but you will find that other people have the same questions. So all questions go in the chat. Please wait until the speakers have a chance to say something, and then ask your questions.
Yeah, and let me just add to that I submitted to Donna, some questions in advance based on questions that we've already gotten from members. So some of your questions may be answered. Donna will address those questions we gave in advance first, and then if there are more questions, by all means, ask them. But why don't we go ahead to Len? Len?
Okay, I'm sharing my screen. I'm going to present a set of slides that will provide the data I think that we need to consider. Let's see. Okay, so this is an overview of what I'm going to tell you. First, the city is proposing to replace the current Medicare-based retirement benefit with a private Medicare Advantage plan. I want to add here a couple of numbers, which I thought would be in the chapter statement that Bill read, but were not. The city has put in its documentation for this that it currently spends $600 million on retiree health benefits, and the MLC, the unions, agreed some 3 years ago that over this year, during this coming year, the city would save $600 million. So those are important numbers that we better keep in mind. Okay, my second point will be that private insurers have greater costs than public insurers and the government. So they take a variety of actions affecting members' access to care to reduce their expenses. Medicare Advantage can work for members as long as they don't need very much medical care. For members who need substantial amounts of care, traditional public Medicare with supplemental coverage, such as we now have, provides more choice, fewer hassles, and lower cost. So here's a short history. I'll go very briefly. American of health insurance in this country. It began as employer-based coverage in the 1930s. The commercial for-profit insurance saw a market, and the 50s joined the market. But it covered only people who were working. There was a strong senior movement, retiree movement, and in 1965, the Congress passed the Medicare program for public insurance for seniors and the Medicaid program, public insurance for the poor. But the Congress, as many of you may know, is very business oriented, and there were continual pushes after that to allow the private sector to get into the act. And so in 1985, the Congress allowed the agency that runs the Medicare program to engage private managed care firms in providing insurance through the Medicare program. But they believed at that time, as everybody knew, that business is more efficient than government. And so they were only willing to pay the private insurers 5% less than it would cost equivalent care for Medicare. It didn't work. Insurance companies joined and then dropped out when they found they couldn't make enough money. So in 2003, during the George W. Bush administration, they revised the plan and changed its name to Medicare Advantage. And I will talk about the details of that in a moment. They also set up the drug plan because the original Medicare program had no drug coverage. In 2010, the Obamacare was passed to fill in some of the gaps for people who couldn't get coverage. And many of us, including our union, are advocating that we move to a completely public program here in New York and nationally. So what's traditional Medicare? It's hospital and doctor insurance, physician insurance, two parts, A and B. Medicare Advantage is actually Part C of the the legislation that creates the Medicare program. Part B has a premium. If you join it, you pay a monthly premium. There are deductibles, and it covers only 80% of the cost of coverage. The patient pays the remaining 20%. This is now bare traditional Medicare. The hospital, in the case of hospital coverage, also there's a deductible and co-pays, and there are no limits on out-of-pocket costs. So the unions have negotiated with the city, and so that currently the city pays the Part B premium and most deductibles and co-pays. There are still some out-of-pocket costs that we who are in that program can possibly pay. The maximum is $1,053 each year. If there were no city support, that is, if you just join Medicare, bare Medicare, the Part B premium can range from $1,800 a year to $5,300 a year, depending. It's income rated now. So if you have more income in a year, your premium is higher. In addition, there will be the deductibles and co-pays with no out-of-pocket limit, but you can sign up for a supplemental or a Medigap plan, and AARP offers one. It's $3,700. There are a number of other companies that offer that. So that's what you would if you have just bare Medicare. So what's a Medicare Advantage plan? It's private insurance. The city proposes a 5-year contract with a private insurer to provide a Medicare Advantage plan to its retirees. CMS is the Centers for Medicare and Medicaid Services. It runs the Medicare program, and it pays the private insurance companies. That's their sole revenue under normal circumstances. In a Medicare Advantage program, usually there's a very small premium. The same services are covered as Medicare, but the Congress has allowed private insurers to cover things that and pay for it that traditional public Medicare is not allowed to cover, like gym memberships, dental, eye, and hearing benefits. The conditions of the coverage and the cost of service is determined by the insurer, but the legislation, the Medicare Advantage legislation, provides that the maximum out-of-pocket cost to a member who joins one of these plans is $7,550. So here's the crux of the issue. Private insurance costs more than public insurance to run the system. The Medicare program has a little less than 2% administrative costs. Basically, it pays companies to process bills. Insurance companies also have bill processing claims, but they have charges, but they have others. In order to hold down usage, they require that the doctor or hospital get prior approval before they will agree to pay for a procedure. As before a procedure is done, the insurance company has to approve it, and that requires that they have a staff who responds to basically physician calls asking for approval to perform a procedure. They have marketing costs because they want to sell themselves and they have competitors. Medicare does not advertise, but the private insurers do. They pay very high salaries, not only to their CEOs, but to other staff. And if they're profit making, as Aetna is, for instance, they make a profit, typically 5% on their of the total revenue that they get. So how do they make money given that their costs are higher? Well, first of all, they get more from Medicare than it would cost if Medicare alone were providing the coverage. Originally, it was 14%. Now it ranges from 3 to 10%. So that's part of it. The payments they get are risk-based. I'll come back to that. That is, they depend on how sick their members are, how sick their patients are. and it's a per person per month payment that they get. All right, second, they make money by charging copays for some of the services that the members use. That has two effects. It reduces their cost for the service because it's a cost share. The patient shares the cost, but also it reduces use because having a copay makes people think twice before going to see a doctor or going to the emergency room because they know it will cost them money. Three, they pay less to doctors and they pay more slowly. It takes months, the doctors complain, to get their payments back. Clearly, they're benefiting from the float in terms of their revenue comes in before their payments go out. But the payments are lower, and so physicians, not all physicians agree to join their networks. And the result is that a patient faces a limited choice of physician and of hospital. Sloan Kettering, for instance, won't join any Medicare Advantage program because it doesn't pay enough. This is just as data on this. This is a recent study looking back at millions of claims, and it found, in fact, that Medicare Advantage plans tend to pay physicians less than traditional Medicare. Now, this may not apply to ours, but in general, Medicare Advantage plans try their best to attract healthy patients, and they do this in a variety of ways by offering gym memberships. If you're in a wheelchair, you're unlikely to want a gym membership. They hold advertising breakfasts at early hours, so people who are able to get up, get out, and get to a hotel for it, and so on. The point about that is what's called the 80-20 rule. 80% of the cost of the spending on medical care in any one year is spent on 20% of the people. So insurance companies want to avoid that 20%. They want all those people who use very little medical care, and so it won't cost them much. That's called cherry picking in the slang. But the other side of it is when they get a patient that's sick or a patient gets sick, they make it difficult for them. The copays are difficult. Getting approval for the procedures is difficult. Getting approval for the medications is difficult. And so the experience of both the studies, both private and government studies, show that the sick leave preferentially compared to the general population. That's in the jargon. That's lemon dropping. They almost all require private approval for most procedures and most actions, most spending. Medicare requires almost none, only for some particular expensive medications. And this is from the Kaiser Foundation, Kaiser Family Fund, that 4 and 5 Medicare Advantage enrollees are in plans that require prior authorization. That means the doctor or doctor staff calls the insurance company to get approval. Finally, there's just plain fraud. There's repeated studies demonstrating and audits done by CMS showing that the insurance companies claim that their patients, their members, are sicker than they actually are, which increases their payments because they're risk-based. And that they the last one said $9 billion in any one year was fraudulent. So finally, I'll repeat with one addition here. Medicare Advantage plans have greater overhead expenses and take a variety of actions affecting members' access to care to reduce their expenses. Medicare Advantage can work for members as long as they don't need much medical care. But for members who need substantial amounts of care, traditional public Medicare with supplemental coverage provides more choice, fewer hassles, and lower costs. If a different type of Medicare Advantage plan is proposed, we need to ask, since their expenses are greater than Medicare's, how will they balance the books and make money? Remember, there's no free lunch. So thank you, and I look forward to hearing from Barbara and Donna.
And why don't you close your share screen? And Donna, whom I've already introduced, maybe Donna, first you want to respond to some of the points that Len makes. I know that you're going to point out that this is Medicare Advantage with a difference. And then I suggest that maybe we go to some of the questions that I gave you in advance. I can share the screen and put them up. And then most importantly, to questions that members here are raising on chat. And I want to thank Donna for her patience. We're in answering questions from individuals, in answering questions from our retiree executive committee, answering questions at previous retiree meetings, and for in general being an advocate for our healthcare and running, I think, one of the most efficient welfare funds in the city. So Donna? Are you unmuted, Donna?
Now I am. Thank you. I want to say thank you for having me. And I want you to know that I am your advocate. I am concerned. I am looking at this coverage to make sure that it is everything that it should be. I just want you to know that my interests are in how this program is going to work for you completely. I am your advocate. I am very concerned. And at every meeting, I bring up our retirees. What will our retirees do? How can we make it better? So please, although I know that change is difficult, and I know that not having experience with this plan makes it even harder for everyone, because I know it was so hard to convince me. So I respect that, I understand that, but please, I really am here for you. I am trying to get the best results that I can get. So just be aware of that. I thank Len for his PowerPoint, but I can tell you that there are, in the last 10 years, I think Medicare Advantage programs have kind of exploded. And in the last 3 or 4 years, they've had a number of significant changes. And one of them is that they allowed carve out for drugs that they never previously did. So there are a lot of changes in Medicare Advantage. The big difference with this plan is that you will keep traditional A and B, which means that whatever you need to do now to see your doctor or your hospital, you will continue to do under this plan. What this plan is offering is any doctor or hospital who accepts Medicare will accept this plan. They will accept the rules and regulations that CMS has in place, not the Medicare Advantage plan. Basically, what the Medicare Advantage plan is doing is picking up your senior care coverage, because frankly, your senior care coverage wasn't being managed. So the expenses that were being paid for the senior care coverage were not looked at. Administrative expenses were not looked at. The profit and all of that was not looked at. Every year the premiums went up, and it still was only paying the 20% that Medicare did not pay. So something had to change. The Medicare Advantage plans that we're looking at, every bidder contractually agreed that their plan would be as good as or better than the traditional A and B that you have and the senior care coverage. Every one of them has signed contractually that they will offer that benefit to you. The second thing that they're doing is, Len is right, there is a risk ratio. All the CMS plans have star ratings. The star ratings are extremely important. The higher the star rating, the more money the Medicare Advantage plans get back. And as Len pointed out, how do they make money? Well, they make money because instead of Medicare A and B processing those claims, the Medicare Advantage plan is processing those and getting paid to do that by Medicare. That's one of the reasons, because Medicare does not want to be processing these claims. It's It's too labor intensive for them to process an A claim and a B claim. It's cheaper for them to pay a company to process the claims. And in doing that, they'll also process the senior care portion of the claims. That's one way they'll make money. The second way is exactly what Len pointed out, the ratio of how sick their members are. But because of the star ratings, what they've come to realize in these last 10 years is they get better results by offering the members better benefits. Benefits like you go into the hospital, you come out of the hospital, you get a phone call. You were discharged from the hospital. How are you doing? Would you like someone to come to the home? Do you need help getting to your next appointment? Do you understand how your prescription drugs are? Can we have meals sent to your house? This is at no cost to the members because they've learned that by keeping the members healthier, they're actually avoiding more hospital costs and more issues related to the conditions. So those are important things. The star rating also mandates a certain criteria that the Medicare Advantage has to meet. And a portion of them is assigned to the members and how you feel you were treated and how, what other things they could have done better. All of that is rolled up into a star rating. So the higher your star rating, the more incentivized they get by the federal government to keep people healthy. So it's not dropping the ball on people who are ill. It's actually paying more attention to how can we keep you healthier. Those are all of the core pieces of the Medicare Advantage plans that are out there now. They will not, I don't know, maybe we should take some questions now. I don't want to keep going on and on and
Donna?
Let me just,
maybe-
go ahead, Barbara.
I was just going to say, maybe Donna should just clarify what senior care is, because you said this would pick up senior care as the main thing, and I think be helpful to just explicate that a little.
yes. Right now, your senior care coverage, most of you get a GHI. So GHI, Medicare, you'll get a EOB from Medicare A or B, and then they'll tell you how much they paid, and they'll also tell you how much GHI paid. It's easy. The easiest one to look at is a doctor's visit. So if you go for a doctor's visit, Medicare sets the rate, says the doctor can charge $100 for that visit. Medicare B will say, the doctor's allowed to charge $100. We pay 80%, so that's $80. And your senior care picks up the $20. That's what your additional senior care covers. It covers the portion of your hospital and medical bills that Medicare doesn't cover, because Medicare does not cover 100%. So currently your senior care works this way. I get a lot of calls from people who are saying, you know, I'm moving to Florida, and will GHI cover me there, or senior care? What they don't realize is GHI will cover you anywhere, because its primary coverage is through Medicare A and B. And that's what will not change in this new Medicare Advantage that they're talking about. So you will be covered all throughout the United States. The territories, of course, Hawaii and Alaska, will all be covered if you go to a participating provider, Medicare, not the Medicare Advantage plan, Medicare participating provider, you will be covered. There may be some things that are related to the 20% copay that I'm working through now to try to understand. Is that an automatic? Does that have to be applied? I know in some cases it is an automatic reimbursement to the member or payment directly to the doctor. That is one issue that I am looking at to try to clear up. So there are some processing things that I'm still trying to understand exactly how they work, and I'll only understand them as I get them to walk through particular instances. But this plan, from what I'm being told and what is in the contract. Now, if they don't live up to this plan, then that's an issue with the contract that the city will then have to sue them to make sure that they live up to what they've contractually agreed to. What makes me comfortable about this is 6 of the bidders, I think all of the bidders agreed that they could do this. They agreed that they would be able to offer a program where anybody, any doctor who accepted Medicare would be in their program. The difference will be that they will do all the processing, like I said, for the A and B, but at the traditional Medicare rates. They are not negotiating with doctors setting rates. These are Medicare negotiated rates.
Yeah, I'm going to share my screen with some of the questions that we sent you in advance.
Mhm.
And before these questions are not listed in any particular order of importance, and hopefully they cover some of the questions that people will be asking on the chat. And then of course we'll go to the questions that are being asked on the chat. Just one quick follow-up to what you were saying. I mean, Len says since their expenses are greater than Medicare's, how will they balance the books and make money? And you addressed that. Are they also getting a subsidy from the city of New York, which now pays $600 million for senior care?
It's not that they're saying they'll save between $500 and $600 million. They will not be at this point.
Yeah.
It depends on which bidder is picked, if they will be getting a premium or not. And that's still something that hasn't been decided yet.
So let's go to the questions here. First question, I guess everybody can see it, but I think it probably helps if I read it. What are the options if you don't sign up for Medicare Advantage? Will the member continue to get drug coverage through the welfare fund, other welfare fund benefits? If the member continued on traditional Medicare, would he or she have to pay their own Medigap insurance as well as that of a dependent or spouse?
They are the drug coverage through the welfare fund. As long as they didn't join another Medicare Advantage plan that has prescription drug coverage, they'd get drug coverage through the welfare fund. They will continue to get their dental, hearing, vision coverage through the welfare fund. That's something that's completely separate and aside from your retiree basic health coverage. If someone decides to choose not to join this plan, they will not, again, this is, it does not appear, because again, this is not completely finished. They haven't completely made a decision on this yet. As Barbara said, it has to go to the steering committee. But it doesn't appear at this point that that the city would pay for any of the senior care coverage, because all of the Medicare Advantage bidders are guaranteeing that they are going to give that coverage. So there's no incentive for the city to just, pay that money when they're going to be getting the same coverage under the Medicare Advantage plan. So I think it would be a very hard sell to get the city to pick that up.
So as it stands now, if somebody opts out of Medicare Advantage or decides not to choose Medicare Advantage, and if they want Medigap insurance, they would have to pay for both themselves and their spouse, assuming they have a spouse.
Again, it hasn't been decided, but my best guess is that my feeling is I don't think the city will pick up the balance, but nothing is decided yet.
All right, and you partially addressed this already, or maybe fully. Can one use any doctor who accepts Medicare on the Medicare Advantage plan? What about hospital access? And then I just quoted something from one example from somebody who sent in a question. For example, what if a hospital has a policy similar to Johns Hopkins, which states on its website, quote, please be advised that Johns Hopkins Medicine hospitals and most Johns Hopkins University physicians participate with Medicare, but we are not contracted with most Medicare Advantage plans.
According to at least 3 of the bidders, they have relationships with most of these hospitals. And although they will put that on the website, they will accept the coverage, and they will work with the hospital to make sure that you're covered. And I think there's only Johns Hopkins is one of them. There may be another one on there that we were made aware of, but those were all of them said that they have working relationships with these hospitals and that they haven't had any problems getting coverage.
What is our access under Medicare Advantage to lab services, to radiology services, to emergency rooms, to physical therapy. And I guess we could go on and on with this list, but
It's the same, it's Medicare. Medicare is primary. Medicare A and B is primary. So the same coverage that the same access you have under your Medicare now is the same access you should have under the Medicare Advantage plan.
what about copays, deductibles? Does one need referrals?
There's no referrals. The copays and deductibles are the same as well, there's a slight increase, I think, in the copays that was supposed to be in July 1st that was going into effect. But the copays and the deductibles that you currently have in your senior care is what you will have, with the exception of that small copay increase that was supposed to go in effect on July 1st. And I think it was $15 the copay went up to. But other than that, it's all supposed to be the same.
And then what are our Medicare Advantage costs for the above compared to our present traditional Medicare combined with New York City senior care?
Again, should be mirroring the coverage you have now. That's what we have in the contract. That's what the bidders have agreed to.
And what about out-of-state coverage for out-of-state residents, for New Yorkers traveling out of state?
If they have the doctor out of state accepts Medicare, again, Medicare is primary. Medicare is the CMS. Medicare is the primary carrier. So whoever accepts them, then they will accept you, just as now, if you were to go out of state and something happened and you went to a Medicare provider, they would take your Medicare. This should be the same.
Let me just scroll down on here so we can look at other questions. How long is the Medicare Advantage contract with the city? I think you said 5 years. What happens when it expires?
Some of them gave us actually, we'll go out and guarantee till 10 years. So it's an option on the city, what they want to take. And again, that has to be decided, but they're willing to go out 10 years.
And then a huge question about transition. If we go to Medicare Advantage, how will members be educated about their options and assisted in making the switch if they choose to do so?
And that is my biggest concern, Bill. That is my biggest concern, is in the transition. And that's what I am trying to get as much information as possible. One of the biggest things will be to be sure that we have all the contact information for all of the retirees, and that we have the best addresses and phone numbers that we can have, so be able to make sure that everybody is aware of the change, and be able to get them the best information we have to get for this. There is going to be a centralized call center that the MLC will, I'm sure, monitor. We'll put, these are things that we're really working on, saying that if this goes into effect, we want to be able to have meetings where we can monitor and see what the call center's questions are and how they're answering them, and to get contractual penalties if certain things are not met. And we did get that into the contract. So I am going to tell you that it is going to be challenging, because it's such a big change, and trying to get everybody all the information they need. So we'll try to do the best that we can, but that is one of my biggest concerns. So I'm paying a lot of attention to it, and I will absolutely share with you as soon as I get information. I will absolutely share it with you.
So the welfare fund will be helping to provide members with information.
We will not. No,
or not. Because certainly I can't. I know people's first instinct is to send me an email, and I know nothing. Plus, don't have the capacity to answer the questions.
No, absolutely not. What we would be doing is there's going to be a centralized department that will be handling the phone calls. So we will give you that information, that phone number, to make sure that the members know who to address. If that member then has issues, the issue is not getting resolved, then we'll step in to advocate. But their first call would be there. And then the MLC as a whole will be monitoring it to make sure that we're not getting too many questions asked from our members that aren't being handled at that level. That's another thing we're paying very close attention to, because frankly, none of us have the staff that would be able to answer this question, and even OLR can't. So they need to have a separate independent section that will be able to help with this transition. And again, that's something that we're working on right now.
So the city will contract with somebody.
No, it's not. The Medicare Advantage plan will be doing this.
Will be doing it? Yeah, I mean, because,
Yes.
I mean, you just mentioned the Office of Labor Relations. I mean,
Office of-
as many of our members can attest, that's a very opaque bureau of the city of New
Absolutely.
York, and members have great difficulty getting any answers from them.
Absolutely. That's why we didn't want that. That's why we said, no, we don't want that. We want to have a separate, the Medicare Advantage provider is going to have a separate department that can be, the members can contact, and then a separate number where the welfare funds can contact, and we can have meetings with them to make sure that this is all being answered, and the number of questions isn't getting out of hand, so we can address things as we notice them happening, so that most of the people will be able to get into the program without great problem. But we absolutely know that this correspondence is critical to the members.
Will the city continue reimbursements for Medicare Part B and IRMA?
Yes, and I can tell you that they've unequivocally, a lot of the MLC people made a very strong point about this, including me, asking, what's going to happen? Are there any plans to drop it? And they said, absolutely no. So I don't know what they would, that's what we're being told. No, there's absolutely no plans to change that.
And what happens if a spouse of a Medicare eligible member is under 65 and presently covered by GHI? Will coverage for the spouse continue?
We're looking into split coverage. That's one of the quirky things that has to be dealt with. So that there's a number of ways that are being proposed right now, but they will get coverage.
So I'm going to stop this screen share, and why don't we go to either Joan or Eileen?
Well, Bill, I'd like to say a couple of things.
Sure, go ahead.
Okay, great. First, thank you, Donna. And I see some questions that have come up repeatedly in the chat that Donna may not have seen that I think are important ones. I have to say, this negotiation is not over, and no one should think that Donna is trying to sell you on a plan. I really want you to hear that. I mean, and I certainly am not. I'm looking hard at these plans. And just so you get a handle on the numbers, Len mentioned 600 million as the cost, and then 600 million what the city has to save. The city has to save that for the entire population it covers, over the entire population, which is 1 million people that the city covers. So all the savings, as they put it, do not come out of retirees. And also part of the effort to, sorry, there's hammering in my building, so if it gets too loud, I'll stop. But part of the effort is to protect the payments that are made into the welfare funds for prescription drugs and protect other payments. So that was the motivation for doing this. The suggestion that I saw from somebody that that Donna or anybody else connected with us is making any money from this, I think is really uncalled for. Donna is spending tons of her time doing this, but there's a real political agenda behind it. And I certainly share your sense that I hear from many of you. Why is this happening, right? Anything where the city says it's going to save money is only going to happen because of either efficiencies, which I think could happen in this case, better administration, or passing more costs on to us, right? Or reducing services. That is how the city, quote, saves money. We are trying to negotiate so our members are protected and you do not lose. Nothing is more important than healthcare. I mean, we're talking about life and death here. I mean, this is not just a dollar in anybody's paycheck. This is life and death coverage. So the negotiations aren't finished, but I totally agree with the sense that some of you have conveyed that they are far from transparent. The requests for proposals were done in the usual way. Those are done. They weren't shared. I didn't see them as a member of the steering committee. And the negotiations have to move through a certain level of detail before we get to see an actual proposed plan. But there, but I am working very hard and have consistently for 20 years on the MLC board to make sure we get to see everything. So I just want to repeat a couple of things, and then there are a few questions, Donna, that popped up that I don't know if you saw. One thing just to repeat so that I can understand it too, is that in the city put down, just to say this, the city of New York has so many covered lives that they're in a position to bargain for a better Medicare Advantage plan than would be available to others. So they're trying to use that. And am I right in understanding that Medicare Part A and Part B, your primary for that will be, as it is now, Medicare?
Yes.
You don't go through Medicare Advantage. Okay.
Well,
And then
the Medicare Advantage plan will be processing the claims,
okay.
but they still have to follow Medicare A and B's rules. They will not be doing, they cannot ask for referrals. They cannot put into place other restrictions that are not in traditional Medicare. They cannot negotiate with the participating provider, because Medicare is saying that all of the participating providers must accept it. So Medicare can't say, CMS can't say that you have to take this and at a lesser rate than we would pay you.
Right.
They have to do it at the traditional rate.
Right. Okay. And then the Medicare Advantage is covering what senior care used to cover, which is the 20% not covered by Medicare.
Yes, and it's also picking up the hospital rider that people paid extra for.
But prescription drug coverage through the welfare fund for our retirees will remain unchanged. Is that correct?
That is correct.
Right, that's an important thing. So a couple of other questions, a few political ones have come up. Are we trying to maximize our bargaining power by going together with other unions, including the UFT? The Municipal Labor Committee, as Bill said at the top, is a coalition of unions. It's all the unions that have employees employed by New York City. It's 365,000 employees, 1 million covered lives. That's the group that is trying to use its power. However, within that group, there is not unanimity. And there are some unions that are 100% proponents of moving this way. PSC is one of the few that has consistently asked questions about it. Donna's role historically in the technical committee, and she's done a spectacular job of this, is to reduce some of the waste in spending that they were doing and call them on that, not corruption, but just a lack of efficiency, and has already saved the Municipal Labor Committee and all of us millions of dollars in that process of waste on drugs. So in terms of the political, it is all the unions together, and that's why we have bargaining power. But many unions are already 100%, we should do this to protect benefits for everyone in the long run, and to keep providing money into welfare funds and health insurance in general. That's why they're doing it. And I guess a couple of other questions that came up. I think a very big question that I have is what happens when the contract ends? Because we all know that, we've bargained contracts with, and Donna does this beautifully for our welfare fund, with, let's say, prescription drug providers. And they're great to you when they're first providing the contract, and then they're not so great to you after all. And if this is a 5-year contract, or even if there's an extender, at a certain point, it's going to be renegotiated. I think we are right to have a concern about what happens when the contract ends. Do they then say all those nice things you had in the beginning, sorry, they've turned out to be not cost effective, we're dropping those? I think that's a serious concern. So I'm going to put 3 things out, Donna, for us. And again, I don't want to position Donna as the advocate for this at all. We are lucky to have someone on the technical committee. We are lucky, and we're lucky to have Donna there in particular. So that's one concern, the end of the contract. Another concern is about hospitals, because you mentioned this question of all hospitals taking this plan, and the MLC has done some work, particularly with Sloan Kettering and Hospital for Special Surgery. So what guarantees are there that Sloan Kettering and HSS will still be available for our folks? And what was the other? Oh, and traveling out of state, out of the country was another concern that has come up. Out of state you addressed, but out of the country is another one. So I guess the three that maybe I'm seeing pop up would be, for me, the big question is what happens when this contract and the sweetness of the first deal is over, and then out of country, and then the HSS and Sloan Kettering.
The MLC is working with them, with the city, to get something contractually, because as you said, they're paying X amount of dollars now. What happens in 5 years and 10 years when they've been riding this wave, and I don't know what happens. It goes up, so then would that be lost? So they're working to make sure that that is something that they would have in writing, so that it's already there how much the city was paying, so that it's not forgotten. I haven't heard any final wording on it, but there was agreement from the city that there would be something that they would be able to do, but what that something is, I don't know yet. So actually that might be a good thing to bring up the steering committee meeting. The other thing that they were bringing up too is that the savings would go into the stabilization, and that's probably another thing that should be brought up. I know that they were talking about getting a letter stating that, but those two things would be very good. I believe that Medicare, you know what, I have to get the out of country. I'm trying to remember. I think I'm getting it confused with the full-time actives. I believe if Medicare covers out of the country hospitalization now, then they would be covering it. So honestly, I have to check because I'm getting kind of confused with the two of them.
And the other was Sloan Kettering and HSS.
I believe that both of them do accept Medicare, and if they accept Medicare, then they are in the program. If not, they will work with them to make sure that they will accept the members.
Okay.
There is the Medicare Advantage plan doesn't have anybody out of the network. So as long as they accept Medicare, you'll be able to go to those hospitals, and they'll work with them to get the other Medicare Advantage piece covered.
Thank you. Because some of our members are now, like the Aetna is there, they have Medicare, Aetna Medicare, or whatever it's called. And I know I've heard from them that they don't have access to HSS. I don't know if they have Sloan Kettering, but we would want to make sure that the access is the full Medicare access, not a restricted access.
They did ask that, and if anybody is looking at going to the hospital within the next, I don't know, 6 months or after October, it would be, if you can just let me know if what hospital. I'd just be curious to find out if I can do some double checking. I'd like to use somebody as an example, to run it by. I mean, that would be the best thing for me to say, I have somebody, and what would happen, when they need to go to the hospital. Those are the things that I'm looking at. I'm trying to look at it from members' view and what you need to do for you, for your doctors, for your hospitals, and how's the best way to handle it. Those are the things that I'm very concerned with right now.
Right.
And I'll find out about
All right.
the end of.
Right.
Why don't we go
other
to
questions.
Joan and Eileen, who have been collating questions, and so either Joan or Eileen, you want to give us another question?
Okay. I think there was one of the questions that came up was both, well, how does it affect pre-existing conditions or catastrophic coverage? And also, would they need pre-approvals for nursing homes, rehab, et cetera, as might exist now?
As far as pre-existing conditions, they can't do that. That's you can go to any doctor you want, and you're in the Medicare plan. This is not an individual plan. This is a citywide plan. It's going to cover all retirees, not just pick and choose which ones they want to cover. It's everyone will be covered. The second question was what? I'm sorry, I'm getting.
Well, catastrophic coverage. Like
When you say
running up
catastrophic, do you mean the traditional, Mercers or that catastrophic? Is that the catastrophic coverage you're talking about?
Well, in the chat question, they weren't naming a specific coverage, but I assume it was because they already had catastrophic insurance coverage from someplace.
That shouldn't change. It doesn't matter as long as you have coverage. You know, the catastrophic will pick up its percentage of what's out of pocket once you meet their deductible. That should not change at all.
Okay, and there was a question about how dependents are covered, younger dependents and other dependents who were like not Medicare eligible, which I think you made.
That's going to be where the split coverage comes in for under 65s. We're looking at also some of the dependents that are disabled and how are they going to be covered. I would assume most of them would be on Medicare. So, but again, those are specific. Those are other issues that we're looking to see how they're going to be handled. But they will have coverage. We're just trying to understand how that will work.
Okay, so the next round of questions, there's a lot here. People, you've been wonderful, really wonderful. There's over 300 people in the meeting, and we probably have 50 unique questions, never mind the repetition of some questions. So you are on top of everything. I guess I could lump some of them that haven't been asked in terms of billing and payments, since the city will switch the billing or the approval to Medicare Advantage to handle the payments. That could be a whole lot slower than what we have now. And then there could be people turned away that haven't been turned away before. And that's coupled with another question about billing, which is the fact that this sounds really good. A lot of people said, yeah, it sounds okay. But, you know, when I go to my doctor, they're not going to be clued into this and they're not going to know. And so it's going to go to Medicare Advantage and I'll get knocked off.
This is, again, what we're trying to pay attention. Like I said, you know, we're kind of caught in I'm kind of caught in like a nowhere land because it hasn't been decided on yet. But we're trying to get the critical questions answered if it does get decided on. So if they go forward with it, those are the questions that we need to have answered, exactly how this is going to work. We need to make sure that all of your doctors and providers know who to bill. So that is something that we're working on now because you would be getting different cards. So
that was another question, yeah.
Yes, so that is something that's, you know, actually on the top of our list, and that should be all part of the communications that we're hoping to have out to you so that you will know exactly what needs to get done.
Eileen, do you want to go to some of the questions you've?
Well, I think one of the other sort of several questions came up with people who were already in a Medicare Advantage program where they might have been paying additional supplements themselves. And now they're curious as to if it turns out that it's the same company that the city chooses, does that mean they will now not have to pay that premium? And will it be this, you know, they're not sure whether they're really entering into something entirely different, or is it compatible to the Medicare Advantage plan they might already be in? And I think there are also additional questions, which I think are related, that are climbing up into the chat, is that even though it claims that if a doctor takes Medicare, he'll take the Medicare Advantage, what they're saying is experientially is that that's not their experience.
Yeah.
In other words, if the billing is going to now have to go to a medical advantage plan as opposed to traditional Medicare, that the docs resist. So who's going to end up doing the education of the docs on this? You know, that's, or you know, that they may lose, you know, they may lose the physicians they want to use.
That's what the stars are in a CMS plan. That's why it's important to get a four-star plan, because they have to meet certain criteria, the plans themselves, or they lose money from CMS. So if they're not getting, if the physicians are saying that, you're holding the money, they're going to lose stars. They lose stars. They lose the incentive for Medicare to do better. So that's one of the things about having a good program that has at least a 4 stars, because that they have to meet all those criterias. So there should not be any of those issues. Will there be? I don't know. I mean, this is something that's very new. All I can tell you is that the city will be held accountable and made to fix whatever isn't working. Initially, if there were these issues initially, everybody on the MLC has been extremely vocal in saying, this is what's being promised and it sounds great, but what happens if this happens? What happens if that happens? So there are a lot of penalties built into the contracts to make sure that the Medicare Advantage plan does what it's supposed to do, and adding to that the city's accountability. And so far they've been good as far as working towards making sure that the plans are as good as we can get them, meaning in the full-time actives. If we see an issue coming up with that, it gets addressed. Those providers are pulled into the meeting, they're questioned, there are penalties, there is money sometimes that's given back because they've made serious errors or they haven't met the criteria they were supposed to. So I do feel somewhat comfortable that everybody is invested in trying to make this as good as they can. But I can guarantee you that there are things that are going to go wrong. I can guarantee you that. But we're going to try to do the best that we can. And that's why it's good for me to hear the issues so that I can go back and make sure they're addressed before they even happen. That is really going to be critical, to try to make sure I find out how this is going to work. The Aetna, I know that the Aetna plan is out there now. I would assume that there are some pieces of it that are probably better than the senior care was. I'm not sure what they are, but again, this is not completely, it's been an ongoing discussion, but I think that there's only going to be one Medicare Advantage plan offered. And that will be at no premium to the members. It'll be at no cost to the members.
So, Donna, penalties imposed by whom? CMS, by the city,
No.
by both?
In the contract, in the city contract, that says that the MA plan has to, an implementation that they have to meet certain criteria, or there's penalties they have to pay, meaning correspondence, meaning getting the communications out, meaning too many people calling in because they have issues and their doctors aren't getting covered, or nobody's handled this issue. And you said all of the hospitals, and why do I have 5 people with this hospital and they're having an issue? They missed their dates, or that type of penalties that are built into the contracts.
What mandates a doctor who accepts Medicare, let's say my doctor, what mandates him or her to accept this plan?
If they are accepting Medicare, they have to, according to CMS, they have to accept the plan. There's some type of, the MA plans do have participating providers, and those participating providers take Medicare A and B, and they automatically get their 20% reimbursement without question. If 41% of the doctors who accept Medicare are participating providers, then every participating provider, Medicare participating provider, must accept the plan. What I'm looking into is the Medicare Advantage plans are also saying, but when we pay them A and B, we'll also be paying them 20%. And those are the kind of issues that I want to make sure how the processing it actually happens. Those are the things that I need to understand a little bit better. But according to CMS rules, your doctor, if he's accepting Medicare patients, if he's participating in Medicare, he has to accept you.
How does CMS enforce that?
I believe that they could probably take him right out of Medicare if he doesn't, because then he's violating a CMS regulation. I'd have to look, but I mean, I'm just
Okay,
guessing that's a CMS regulation, not a Medicare Advantage.
right.
But for doctors that now take Medicare, they could opt out, right?
They can, but they'd have to opt out for all of their patients.
Of
And-
Medicare, right, Donna?
Of
If
Medicare, they'd
yeah,
have
of
to opt
Medicare.
out of Medicare.
Yeah, we
And that's a pretty big deal
Yeah.
because if they do that and then you continue to see them, that you have to sign all kinds of release papers and verifications that you know he doesn't accept Medicare. And that means that he can charge you whatever rate he wants to charge you because he's no longer in Medicare. So I know that there are some doctors who do it. I'm not quite sure what benefit they get from it. But I know it's a very big deal. And I think that the last percentage, if I remember correctly, is it's less than 4% of the doctors that don't accept Medicare at all. And they may very well be the boutique doctors who treat a certain clientele of people and they just don't take Medicare.
Can I jump in for a second on the process? And I'm sorry, I had to be on the phone. We thought the budget was wrapped up in Albany over the weekend and they're still doing stuff and we're trying to get higher ed. So sorry, trying to get higher ed in get a little more for CUNY, which helps everybody, even though some of you are adjuncting still, but most of you are not working at CUNY now, but so I apologize. I just want to say one thing on the process and also this issue on the savings that came up earlier. The quote savings, and I want to stop every time I use that word because that's the city's language. It really it means they save. It doesn't mean we save. But the people should not think that the entire amount, not only is the entire amount not coming out of retirees, but also a big chunk, the biggest chunk of the reductions this time came from a requirement that new employees at CUNY, community and senior colleges, have to go for their first year on HIP as their health insurance. After that, they can transfer. Actually, quite a surprising number of people don't, surprising to me anyway, but that was the biggest savings in this agreement. So just so that people know, all the other changes have affected actively working employees. This is the first for retirees, and I think it's really, really serious. I don't know if Donna said this when I was off listening, but the biggest change that needs to happen is that the big private hospital chains charge inordinately high prices for simple procedures. And the biggest effort to use the bargaining power of unions together is to force those hospitals not to charge 6 times more for colonoscopy, endoscopy, whatever it is, than can be charged at other hospitals. And also not to charge that same amount at their branch hospitals, where they're now gobbling up all these small hospitals all over the city, not to charge the same amount at their branch hospitals, maybe as at their central hospital. So they've jacked up the prices tremendously. And the biggest effort on getting prices down is to cut into the giant overheads of those hospitals, particularly how they have in those hospitals that refuse to unionize and various other things. I mean, there's some serious issues with those private hospitals. So but just so you know, there are other ways that this reduction has already occurred. And the other thing I want to say, which I think is really important, is about the process. The deal is not done. The deal is not done. But I would be naive if I thought that there wasn't a lot of pressure to get it done. I think the majority of unions in the MLC are pushing very hard for this to get done. Why? Because there's been tremendous pressure on the health insurance of the entire universe that MLC covers, tremendous push from in-service employees whose copays have gone up tremendously as the city has made these changes, as health insurance costs have gone up and up. There's a lot of pressure on other unions that they, on us too, but that we're resisting. And a lot of unions are very much supportive of this. Many are not examining it as closely as Donna is, but I know some are. I think UFT retirees met, and I think DC 37. I will do everything I can to press for a more transparent process, because I think that we are, you know, it's not just you who are retirees, but it's anybody who aspires to be a retiree. And as Bill always tells us, you know, we are retirees in training, right? If we're lucky, we'll get to be retirees. So this is not about the 250,000 retirees. This is about the 1 million people covered in the MLC. And everybody has a stake in this. And it's I think most critical for you right now, because it's your lives and a transition potentially for you. But this is about everybody. And, you know, hearing this and listening to your questions, realizing things I don't know yet, makes me think about ways I can work with Donna, with the other unions, to get a more transparent process. There's no reason that members shouldn't, at a certain point anyway, see this proposed contract. I realize we can't all be in the room when every detail of a contract is being negotiated, but we can hear what's being proposed and direct our representatives to vote in that way. And when we weigh what's being proposed, we have to think of what the alternative is, and what the impact will be on our welfare funds and on other things if we don't move forward with this. So I think we should really have the time for all of you to see in a very transparent way, and slides as clear as lens, what is on the table, what is not, what is promised, what is not. For me, the big question of what happens at the end of this contract needs to be answered. That is a definite concern, and something I'm going to press on, also press on the process. So I wanted you to know that. And I just want to throw out one more thing for Donna. It keeps popping up in the chat, even though you've answered it. Dental, prescription drug, optical, what are other benefits in the welfare fund, hearing aids, those are all untouched by this plan, correct? Untouched.
Correct.
Those remain the same. So yeah, I just wanted to say that about the process and how important it is for me to hear all this and to press on this process and, you know, use the bargaining power we have, and protect all of us, all of you.
Yeah, Barbara, you mentioned that other unions are pushing for this. From what I know, other unions have not had as transparent a process as our retirees chapter has. The UFT recently had a meeting, which was a webinar where questions were not allowed. Many people in other unions have found out, retirees in other unions have found out from our members that this is happening. So, I mean, obviously I want the process transparent for our members. I want the process transparent for all 250,000 municipal retirees.
Yeah, no, I should. I thought I didn't know that about what you just said, Bill, I knew the UFT was having a meeting, but I didn't know about that. I mean, I understand that there's bargaining on every detail. There's looking at every line of a contract. There's making, you know, trying to push them and everything. We're not going to sit in a room with 365,000 people and do that. On the other hand, hearing what's up before it's too late to have an impact on it, I think is the important thing, because, you know, things move forward and they get a lot of support, and it's hard to move them back. I mean, and there's a lot of, I would say, and Donna might have more to say, but I think there's a lot of momentum to get this done and to protect the stabilization fund, which is the fund that provides money for welfare funds across the city. And that fund is being drained and drained and drained by costs of prescription drugs. And there's a momentum to keep that protected for everybody. So yeah, I think you're right, Bill, and it's something that we can intervene on, at least try to intervene on.
Right. So let's get back to Joan and Eileen. And
Okay,
you know, I know there are more questions in the chat, and it's really important that we
jump
get to
in
them.
with a housekeeping because there's some individual questions, my husband and I and my kids and etc. And Donna, can you give us an email address in the chat where people could send individual questions about their own plans?
Yes, you can. If you wouldn't mind sending them to communications,
Right.
COMMUNICATIONS @PSCCUNYWF.org. That'll go right to the welfare fund, and then I'll make sure that they get answered either directly by myself or Pat Smith.
It's PSC.
It's communications, the word, at
Yeah.
PSCCUNYWF
CC.
as in Frank,
Right.
.org. So when you read it, it says PSC CUNY with the WF at the end of the welfare fund.
Right. Okay, so then that goes into general.
It will, but I will get them. Pat will get them. That would be the easiest way for us to handle them.
Okay, and to reiterate another thing that has been said in the beginning, Donna, that you said and others, you can't, if this happens, you can't keep your regular Medicare. You can't have both.
Yes and no, because this is your regular Medicare.
Right.
It's just that it's going to go through the Medicare Advantage provider, but it should look, well, it won't look, because you'll be getting an instead of getting an EOB from Medicare Part A and an EOB from Medicare Part B, you'll be getting one EOB that says Medicare A or B paid this much, and the Medicare Advantage plan, which would have been your senior care, pays this much. So you'll get one EOB at the end of the month, which actually should make it a little bit easier.
Well, but we get a different card, and people are worried about that because when they get to a doctor or a hospital and present it, and they say, no, we don't take advantage.
And that's exactly what I'm trying to get addressed now, because I want to know exactly what happens when you go to the hospital or you're anticipating being admitted to the hospital. You call, they tell you this. I want to know point by point, what do you do? Who do you call? They're supposed to call the hospital administrator. The hospital administrator, then the Medicare Advantage plan should call you back and tell you you're good, you're fine. Those are exactly the things I want to get answered.
Yes, and of course, the anxiety of needing care right now.
Absolutely.
Yes, that
And
can happen.
another
No.
letter in here
And
where,
they're telling us that it can't and it won't, but just like everyone else, until I see it not happening, I also am concerned. I need to see something happen so that I feel confident. The only thing that is making me have some sense of comfort in this is that we have the penalties in the plan, and all of the bidders said that they can do this and that they are doing it. So I am skeptical like you are, because I haven't seen it work for myself yet, but I do have a sense of comfort in that it's not just one plan telling me they can do it, it's three of them. So I will feel a little bit better when somebody just walks me through how exactly that happens. Because that is something that I want to be sure doesn't happen.
Eileen, over to you with a
Well, it seems to me partly what's coming up also is concerns about if it's not working well, where do they complain and what is their redress? And I think the idea that it might be a process like complaining to CMS is not useful, I think, in the short
No,
run.
you wouldn't go to CMS.
But
You will go to the Medicare Advantage. There will be a certain department, a certain number that we will get that will just handle city retirees and this plan.
Okay.
And that's where you should get your answer. And again, we'll be holding them accountable, because then, and this has already been brought up, we know our members are going to call us if they're not getting the answers that they need. And then if we get involved, then we will be calling, and we will not, that will be, there'll be a penalty involved, because this was supposed to be taken care of. And as I said, we'll have, I'm sure, just like we did with the HIP, there'll be monthly meetings, or maybe in the beginning, they'll make more frequent meetings to see what is happening, and to actually call the Medicare Advantage plans in on our meetings to answer these questions and find out what's going on, what have they done to address the issues. And so far, we've been, from my point of view, they've been very receptive, not on the Medicare Advantage side, but on the active side. We've gotten a number of things that we didn't like the way they were going, and they were fixed. So this is what we're looking to do, use that as the model to make sure that the Medicare Advantage plan is also working. But we are all very concerned about it.
Let me just note that I just put the email address that Donna mentioned, communications, at the welfare fund, in the chat. So the email address is there. But I'm sorry, go ahead, Eileen or Joan.
I think the related question is, if folks are really unhappy and choose then to pay, if the Medicare Advantage is essentially replacing the Medigap coverage, and the rest of our coverage is through the welfare fund, well, can they choose to do another Medicare gap thing that they pay for themselves, and then keep whatever, I guess it would be their reimbursement for drugs and dental and all that stuff as they had it before, and they would just eat the cost?
One thing would not affect the other.
Okay.
But I would hesitate to do that. And if there really is that type of an issue that would push some of our retirees to say, I'm not doing this, then we really need to take other steps to make the Medicare Advantage plan more responsible for what they're doing. In our drug program right now, we have something called like Adopt a Member. And that means that member, we can get somebody on SilverScript's side who our member can call and talk to them directly about their issues. And that would be for somebody who's having a real problem for whatever reason that's not getting resolved. They've called, I don't know how many different times, and they need to have somebody who's going to be responsible, that has a name that you can keep calling. And of course, we get involved in it, and that usually solves the problem. So that person then follows whatever that issue is. That person on the Medicare Advantage plan would follow that member to make sure that it got fixed. And if the member continues to have problems, of course, that would be coming back up. We're looking to do something for them to have something similar in this program, so that no one member will get into that type of a vicious cycle where they call once, it's going to be fixed. They call twice, they don't know what you're talking about. You call 3 times and it's, who are you? To not have that level of frustration affect any of our members, to the point where you'd go and you'd pay $100 a month for a plan. I mean, that would be crazy.
I think
go ahead, Eileen.
No, I was going to say, I think also another sort of indirectly being asked, because it's the questions about how the city is going to save money, et cetera, and comparing what's happening with Medicare Advantage for retirees compared to the in-service new hires being required to use HIP for a year. This is now a really pretty permanent solution being offered to retirees. So it's not like there's a 2-year contract, and if we're not liking it, we can get out, as would happen for the in-service people who didn't like HIP. So this is like, a 5-year contract, and then the expecting of a renewal could be, this is a pretty, like, in other words, whatever's going now is probably very likely to be permanent for the retirees.
It is. And I can tell you that all of the other unions, and the UFT is pretty sensitive to this also. So with DC 37, UFT, and us, if that were the case, then they would be making sure that Medicare Advantage then made those changes. If there was something that was not, because this is all in the contract, and they wouldn't be adhering to the contract. If they are not providing the same level of care that you're currently getting, this is not, contractually, they're out of, I forgot the word. They're not following the contract. So we'd have legal recourse to take because they're not doing what they're supposed to be doing. So it would be a very big issue. So again, those are the things that I find some sense of comfort in saying that it's got to work, because they've got all of these things in place. If it doesn't work, and I don't think any of those plans, the Medicare Advantage plans, want to fall on their face by providing less than the coverage they should have to New York City's retirees. That would be a huge issue. I mean, that would be a huge black eye. So those are the things that I believe are going to happen. But like I said, I absolutely can understand the hesitancy and the concerns. I don't know what else to say.
Can I just do a little housekeeping because there's a lot of people who came in the middle.
Okay.
And towards the end. So Barbara has been reading the chat, as has Bill and Eileen. And what we're doing is we're clumping the questions. So to reiterate, if you have a specific one, you write to communications at the welfare fund.
Yes.
But we're asking the general clumps of questions. And some of them are coming up repeatedly. So can we make this Zoom available to people with the chat?
Yes.
Okay. So
The Zoom will be available generally. I mean, Samantha, who's staffing this from the PSC, generally gets me a link to the Zoom recording a day or two after the meeting, and I will put it on the retirees webpage, which is psc-cuny.org/retirees, and it'll be there prominently. Or you can send me an email at retirees@pscmail.org, and I'll give you the link. But wait a day or two, that's when we'll be posting it on the webpage. And you'll be able to see this entire meeting in all its glory or agony, or however you want to describe it.
So thank you. There are a number of questions that are more general in scope, and some of them lead back to Len's opening remarks. So did the Municipal Labor Council consider a public option rather than switching us to private? That's one. And within that, are all the unions involved in this, including the police and fire?
Yes, all the unions are included in this. And I don't know what other public option would be available.
Well, New York State single payer, the Health Act.
But it doesn't exist yet. So
Yes, but it's in both houses. So,
And they'll allow Medicare. They'll allow Medicare people into it. That would be unusual.
yes, I believe that would be. But it hasn't passed yet. It's in both houses, but it hasn't passed yet. So we couldn't count on that as the source. And I'm not sure, as Donna says, and Len, I'm sure knows about the relation to Medicare. So that would be another question.
If this were delayed and if we pushed for that act to pass, then it's a public option rather than a private option.
there's so many unknowns about that program. Not only, like you said, if it got passed, but then there'd be so many unknowns in trying to look at it and to see if it would possibly work. They're concerned now because the healthcare costs are every month, it's getting worse. The stabilization fund is losing more and more money, so we can't really, the city can't delay this. In the past few years, you may not have realized it because you weren't affected, and maybe you did if you were still active members, but they were taking a lot of measures and increasing actives, their co-pays, their emergency room pays, their initial hospitalization deductibles. They were making huge cuts, I think, and if I remember correctly, they were citywide. It was over $3 billion.
3.5.
Yeah, so now they're looking to look at the retirees to see how they can get some savings there, because honestly, in all of the meetings, it was said, don't touch the retirees, don't touch the retirees. So they're very sensitive to retirees' healthcare. But as Barbara said, the healthcare costs are they're just through the roof. They're trying to find the best way to manage them and still provide the best benefit they can. So the short answer is, in the future, that might be something that can be looked at depending on what that coverage actually turns out to be and who can be in that coverage. But in the short term now, we need to go forward, whichever way forward is, otherwise it's not going to get. There are going to be other things they're going to cut back on, and I think that's the fear that everybody has, is if not this, then what? So
I just, I'm sorry, Donna and
no,
Bill.
it's okay.
I'm getting called that I have to leave in a little bit, but I just want to say two things. One, I see a question in the chat, is PSC on record supporting the New York Health for All Act? Yes, we are. It's been extensively discussed by the retirees. I believe in our position, I mean, we have supported it. We do feel that there are issues that concern unionized employees that weren't sufficiently covered in that, and we're still working to get those changes. But we, PSC, NISNA, that's the nurses union, a few others have been, and I know Len knows them all, have been supporting that. But I wanted just to go to the larger framework, because I would put it a little differently. I mean, yes, the active in service, actively employed employees in the city have so far been the target of all of these cost saving measures. And now they're looking at retirees. That doesn't mean that it's okay to do either one. I mean, I just want to say that it is not okay to do either one. The whole drive to do, quote, cost savings is within a framework of fiscal austerity that the PSC is working actively to reverse. I mean, that's the framework, and we should not normalize the idea that reductions in service are okay, right? That's just par for the course. There have been other changes. Some things can be done more efficiently without hurting members. Here's one way that the MLC or the city saved money to try to get lower costs. Here's one way. They did an audit of how many people were fraudulently on city health insurance, how many people who were really 38 were posing as 26 to be on their parents' plans, how many people who had been divorced for 35 years were still listing their person as the spouse. That was one of the ways they saved. I mean, there are a lot of ways to save. Some are okay, but some are not okay. And the framework that all we have to do all the time is save, rather than get the city to have more income so the city can spend more, and so that there's less profiteering by the hospitals and insurance companies. That's the framework we are trying to produce. And we are actively working on that framework, including right now on my calls to Albany. We are actively working against an austerity framework, actively working to get more progressive taxation in New York State. So there'll be more money for the state and the city, and less of this drive, not only to do reductions in healthcare, but to normalize reductions in healthcare. So while I agree that there are certain things that can be, where costs can be reduced through actual efficiencies that do not hurt us, there are other ways that do hurt us. Either we're paying $100 for an urgent care visit versus $50. That hurts us, right? And many, many other things. We are trying to, get your temperature on the Medicare Advantage. And I was interested in people saying maybe we should call it something different, but we're trying to take your temperature on that. So Donna and I can be the best advocates we can. We're trying to learn whether we should try to stop the process, subvert the process, or make the process as advantageous to you as it can be. But at the same time, that doesn't mean that we should accept the framing that the only thing to do in healthcare is accept more and more cuts. So at the same time, we are advocating. So I want to hope that I can convey that these concerns are absolutely urgent. And I'm hearing people write about their own doctor, their own hospitalization. Nothing is more urgent, right? We are doing two things, right? One is to work to hear you and use our own judgment and look at experts and see if the PSC's position should be, we should not do this change. B would be, are we saying that here's a way that the change can be done that is not harmful? That's what we're looking at right now. And I guess C on that list would be, what ways can the process be made more open and more inclusive and less normalizing of reductions in healthcare, less normalizing of those reductions. And that's really our goal, to protect our members and advocate for our members and to change the frame, because we're going to be back here talking about some other change if we don't change the frame. So, but we can't wait till the change is made in the framing. We have to address this now. So that's what we're trying to do, address this as forcefully as we can now, as smart as we can now, and try to change the frame. So I hope that gives a sense, and it's been so useful. I know I have to get off in a minute, but I want to say it's been incredibly useful for me to hear this, and I'm sure for Donna too, as we go into those meetings. For one thing, it allows us to say, we had 300 members on a call talking about this. We know what we're talking about. And so I really thank you for that. And we'll keep at it. And we are very, very lucky to have Donna in there listening and fighting every single day on every issue, large and small. So thank you so much for that, members. I really appreciate it. And Bill, I'm sorry, I have to sign off.
Thank you, Barbara.
Thank you, Barbara.
Thank you, thank
But
you.
everybody stay on. I mean, I know
Yes.
Donna's going to stay on.
Others, stay on, stay on. I didn't mean to end the
Stay on.
meeting. So
And
Well- Maybe it's time for the poll now,
Oh,
Bill,
yeah,
before some people are dropping off. So
yeah, Jim Perlstein, why don't we unmute Jim Perlstein, who has a poll question for us, or a proposal.
Okay, well, I'd like to, I'm disabled for screen sharing. I'd like to post a proposal on the screen.
Yeah, I'll post it for you.
So,
Give me a moment. Um,
can you read it meanwhile? Oh, there it
Okay,
is.
there it is. Do people see it? Is it on the screen now?
yeah, I can see it on the screen.
Okay,
And I just, but by way of introduction, I mean, I think that our leadership has been tremendously responsive to the concerns that the retirees have shown. And I have complete faith in the good faith efforts that Donna and Barbara and leadership generally is making on this issue. But what's clear to those of us who are active on this healthcare issue and are in communication with other retiree organizations in other unions is there has been no discussion such as the one we're having in any union in the city besides the PSC. And for that reason, I would ask for a vote on the following resolution, that we're requesting a moratorium from the MLC tripartite committee proposal to change municipal retiree healthcare coverage. As a matter of urgent concern, the retiree chapter of the Professional Staff Congress requests that the PSC as a union seek a moratorium on any agreement between New York City and the Municipal Labor Committee to move retiree healthcare coverage from Medicare senior care, which is what it is now, to Medicare Advantage. Municipal retirees affected by the proposed change to retiree coverage have not been provided adequate and timely information, nor have they had opportunities to discuss and debate the controversies around Medicare Advantage plans, the personal effects of such a change, and its policy implications. So we're not calling for a vote to oppose the change, but we're saying, whoa, slow down. We don't even know, but we hear the deadline is July 1st for the introduction of this new proposal. Say, slow down and give folks a chance to understand what the plan is and discuss it. So it's on the table for your comment and vote.
This is a poll. We're asking, do you approve of the resolution? And no, don't you? You do not approve of the resolution. And we just want to kind of get a sense of the body. So if you could answer yes or no.
Bill, how do people vote?
That's a good question. Samantha, how do people vote?
I just put the poll up, so you should see a question appear on your screen where you could say yes or no. I already see that some people are voting.
And
then,
I think for those of us who are hosts or co-hosts, we don't have that option, but I think everybody else does.
Yeah.
So Joan, that's why we're not seeing it on our.
Okay.
Oh, okay. So we can't vote.
Right, we can't vote. We're disenfranchised. So why don't we take another 30 seconds and then we'll end the poll. So why don't we end the poll? It's pretty overwhelming, 93% to 7%. If I can read my screen correctly, it's 188 to 14. I mean, this is not quite the same as the resolution, but it certainly gives us, a sense of the meeting and of where we want to go, our leadership to go on this. Joan and Eileen, are there other questions in the chat? That need to be addressed?
There are no other real unique questions. There's individual questions. And there's some interesting discussion that people could read. Eileen, do you see anything that's not?
No, I don't. I think there were a lot of, I think it's also clear that some people came into the meeting a little bit later, so they didn't hear some of the earlier discussion. So, but those questions had already been addressed. I mean, I think there's still lots of people talking about how they can pay on their own, but, I would forewarn people that that could be quite a pricey alternative. And I think the other thing that I think is that people are asking for, I think in a general way, is that This might make it easy for people to accept what is finally negotiated, is if people could see, like almost in a chart like Len had done, what people have now, whatever the proposal is would offer, and where there would be changes. And I think, and I know that Donna and her team will have answers to some of the questions that we couldn't answer on the spot, so that, and I think we can look at that too, to see if there's anything else we've missed that hasn't, been addressed. But I don't think there's any, like Joan, I don't see unique questions. It's really a lot of the similar questions being asked.
Yeah, I'm going to put in a moment the email address to contact the welfare fund. I mean, I'll try to share the screen again and see if I can put that up.
The only other thing I think that our Social Safety Net Committee addressed, because we had a speaker to that effect, is short of the New York Health Act, many other or almost all other cities or states the size of New York are self-insured, and that does save money. And potentially the person who presented to us proposed that would save even more than what's being proposed to be saved by the Medicare Advantage program. But again, that kind of change, I think, is very hard to turn around in a short time.
Right. So the Municipal Labor Committee, when they put all this stuff on the table back in the fall, they put 5 or 6 items on the table. One of which was moving retirees from traditional Medicare with secondary insurance by the city to Medicare Advantage, but one of which was the city self-insuring. My understanding, and of course now Barbara has left the meeting, is that there's been absolutely no discussion of that. We would like the Municipal Labor Committee to look into other options. Obviously, we've expressed the sentiment of this body that we want there to be a moratorium by the Municipal Labor Committee and a moratorium in MLC. OLR is the Office of Labor Relations of the City of New York. We want there to be a moratorium on the negotiations. I'm not optimistic that this is going to happen. I mean, as Barbara indicated, there seems to be a lot of momentum, particularly by some of the bigger members like the UFT and DC 37 of the MLC, a lot of momentum for this to happen. This doesn't mean that we're not going to go in there and try to effect a pause. But I think that's where we are right now. Donna, I just want to ask you, do I have the correct email address up there?
Yes. I just saw it.
And it's communications@psccunywf.org, psccunywf.org, communications@psccunywf.org. I mean, in terms of specific questions about this, I mean, even policy questions, I'm not really the person to ask. I mean, you can send questions to retirees@pscmail.org, but basically I'm going to refer them to the Welfare Fund. I thank Donna and the Welfare Fund, for taking on a lot of the burden of education on this. And obviously, I think what we're in for is a really kind of, pardon the word, messy, maybe that's a charitable word, transition period, if this actually happens. And clearly today, I think, members of this chapter expressed their very deep concern and angst about this. But of course, Donna has tried to reassure us that this plan will provide us with just as much or maybe even more than what we probably than what we already enjoy with traditional Medicare and secondary insurance now paid by the city of New York. Let me, yeah, go
John
ahead.
and Jim seem to both have their hands up. I think John, John, why don't you unmute yourself and say what you were going to say or ask a question?
Yes. First of all, thanks to everybody who made this meeting possible. And it was very important. My question is, where do we go from here? I don't expect us to be able to address that right now, but I do think we need to think about that. What are the next steps of the BSC retiree chapter in response to all this information that we've gathered today? And is there some way we can begin to put our ideas together on that? That's it.
Yeah, I think clearly what has to happen is that the executive committee of the retirees chapter has to meet and debrief about this meeting. We need to hear from people. And obviously, this is not going to be the last word on this issue. We have another chapter meeting scheduled for May 3rd. It's supposed to focus on the new deal for CUNY, but if necessary, we'll focus on this, or we'll call a special meeting. And then, of course, we also have a meeting in June, on June 14th, when Barbara is going to look at her 21 years as president of the PSC. And of course, as people know, she's stepping down in May as president of the PSC. I guess, you know, I can't give you a satisfactory answer, you know, or a final benediction that very neatly wraps up this meeting, because it cannot be very neatly wrapped up. What I do want to say is thank you to Donna for your patience in answering our questions, for the fact that you're always there to answer questions, you know, and I think have been a long time advocate, you know, for our healthcare as executive director of the PSC CUNY Welfare Fund. I think we need to do more on this. We will do more on this. This is not going to be the final word. But I think, as everybody understands, this process has not been very transparent for the 250,000 municipal retirees. And as Barbara stated, and as we have made clear, and as Jim stated, no other union has had this kind of no other union's retirees chapter has had this kind of meeting and this kind of transparency. And I think our transparency has a long way to go in terms of what we do and what we know and what we explore. So,
Bill, can I ask Donna 2 questions before
Sure.
we end to take back? And they're not questions I want her to answer now, but I think she really needs to address them.
Go ahead.
Is she still here? I saw her, so I think she's still here. One is, she said that the bidders, at least one of the bidders, said they would save $500 to $600 million, which is what the city needs to save. And I would like to ask her to ask them to document that. Certainly a phone call to a discharged patient is not going to save that kind of money. That's the total that the city now spends. So I think she or the whole committee should be asking them, how do they propose to save that kind of money?
It's in the contract. They've already put it in the contract.
But
So
how can they do it? I want mechanically, what is the change? Medicare.
They can do it because they're getting paid to process Medicare A and B. They're getting a loss ratio. They're processing the claims. They're taking that burden off of the federal government. They're getting a rate. They're getting the loss ratio depending on how ill a patient is, just like we get on our Medicare Part D subsidy. And they're also getting, their ratings are going to go on how well they can keep their members healthy. So their star ratings go up and they get more money. Len, I can tell you, I had these questions.
Not adequate. Those are not adequate dollars.
I can tell you,
Medicare already, excuse me, Medicare already contracts out the bill paying to entities around the country. It used to be contract with Blue Cross. It now contracts with something called National, I can't remember its full name, but they already contract that out. This is not a saving compared to what Medicare Advantage plans
Well, then
spend.
that's probably a question best asked of Medicare. Why are they paying them that much? I don't know. I can tell you that on our drug subsidies, RDS, before we went to a Medicare Part D program, RDS would pay us 28% of the drug spend. I can tell you that when we went to the Medicare Part D program, we're getting everything. We have members that are over $200,000 a year in drug spend. And all of those people, when they get into the catastrophic phase, the government pays 80% of their drug costs because it's subsidized by the federal government. When we went into the program, I felt just like I feel about this one. This sounds too good to be true. It wasn't. It's because of the governmental subsidies that are paid into the program and the incentives that they put into place for people to have these programs. Part of it was they did get money from the some of the drug manufacturers, which I don't even want to go into that. I don't know if that was a good or a bad thing, but the savings are there, and the fact that they were willing to put them into and in writing, I'm going to say that between 500 and 600 million is what they're going to be able to save. Hopefully, you know, and they're putting in more programs in place. So it's something must be working, because there are other Medicare Advantage programs out there that CMS is looking at before they're going to agree to pay this to other companies.
Is the city also paying them?
We're looking at a few bidders. One of them will be charging a premium for the first for 2 years, and the other will not.
Premium that the city will pay.
Yes.
And Len, you had a second question?
Yeah, the second question is, you said that Medicare requires that or CMS requires that if a physician participates in Medicare, they have to participate in Medicare Advantage. That's clearly not true.
I'm not saying, no, you're misunderstanding, Len. So this is where the HMO piece of it and a PPO, this is more of a PPO plan, are different. I'm saying this plan, I don't know about other Medicare Advantage plans, and there has to be at least, God knows how many out there, hundreds of them in October. All you guys get inundated with mailings on it. This plan, I can't speak for the other plans. This plan says, if you are a participating provider in Medicare, you will be covered under this plan, not any of the others. I know I saw a question out there from Aetna. It has nothing to do with anybody else's plan. It's this plan.
All right, we're going to have to.
We still have two people with their hands up. Marcia, Jim and Marcia.
Yeah, Jim and then Marcia, and then I think we've got to call it a day.
Yeah, I just want, I saw a question from Nanette Funk in the chat and then from John online, what's next? And I think at a minimum, at a starting point, we should consider circulating the resolution that we passed so overwhelmingly to the other municipal unions, and perhaps accompanied by a message that encourages them to have a similar discussion with their membership.
We certainly can do that. And then Marcia?
Hi, this is off topic. I'm announcing that the program committee of the retiree chapter has approved a ticket for 25 to 30 people to attend a working theater performance. You know, we have as a group have gone to working theater every year. Well, this time the PSC retiree committee is paying for 25 to 30 tickets to a performance on the evening of May 8th, which is a Saturday at 7 o'clock. And it is something called Missing Them, an event about all the New Yorkers who have gone. and a sort of and a memorial sort of thing that they're doing. That, you know, they're always very creative, the working theater. Like the time they produced a play about immigration inside a truck parked in the lobby of parked in the parking lot of St. John the Divine. So it's not the expected thing. It's at 7 o'clock. All you have to do to go is send me, Marcia, an email. And my email is, and I'll put you on the list. First come, first serve, 25 to 30 people. That's Revolu. Bill, maybe you could put it on the screen. Revolu, REVOLU, @earthlink.net. You send me your name and and send me your email, and I will put you on the list.
Put it in the chat, Marcia.
Okay. And the thing is that it will be on Zoom, so you don't have to leave your comfortable, wonderful house. For May 8th at
Okay.
7
So
p.m. Okay.
Thanks, Marcia. Anyway, this is not the last you're going to hear from us on the issue of Medicare Advantage. We'll keep you updated with email blasts. I assume that part or all of our May 3rd meeting will also deal with this subject. Stay tuned. We'll put updates on the Retirees Chapter webpage, which is psc-cuny.org/retirees. I want to thank Len for his presentation. I want to thank Donna, as always, you know, for her patience. Answering one question after another. And I want to thank her for inviting people, if they have questions, to send them to communications@psc-cuny.org. And I think with that, we're going to end this meeting. Thank you, everybody, for your patience, for your questions, for your concern. We will continue to pursue this issue. Thank you very much.
One more thing, Bill, before we
Sure.
jump. I'm going to try to put together an FAQ document because a lot of these are the same questions that have been asked and answered, and even in some of the emails that I've answered already. So I think it might be helpful. I mean, one of them is the grid that I've shared, but maybe we can put it, I'll send it to you. Maybe you can put it on the retiree site. Maybe we can put it on the welfare fund site with just an answer, like the grid for the senior care coverage that there is now, so on and so forth. Might be helpful to be able to refer people to it.
Sure. I mean, if you send us FAQs and responses to those frequently asked questions, send it to me as a Word document or as a PDF.
Sure.
And I'll post it on the retirees website.
Okay.
So thanks again, Donna.
Thank you. Thank you, everyone.
Bye-bye, everybody.
Bye, everyone.